This is Michael Altos recording Opioids and Context-Sensitive Halftime, Part 1. First, a little bit of history. Opioids come from the word opium. Opos actually means juice, and it is the juice of the poppy seed flower. This juice has been known to have certain effects for more than 2,000 years. It was named morphine after Morpheus, the god of dreams, in the early 1800s. And this drug has really been known in various forms for quite some time. In the Civil War, it was already being used as a pain medication for battlefield injuries. But people quickly saw its use was limited due to significant respiratory depression and a lot of people dying from the opioids instead of from the original injury they sustained. Today we use the term opioid to refer to any substance, whether it's natural or synthetic, or even if it's endogenous, meaning that it's made inside the human body, any substance that has morphine-like properties. And in fact, in your body, you do have endogenous opioids. We have substances called metenkephalin and beta-endorphins. And when people talk about endorphins, these are the substances they're talking about. And these substances bind to a number of different opioid receptors that are located throughout your body. And the opioid receptors have many, many different subtypes. This is an entire lecture in itself, perhaps a whole textbook in itself. But for our purposes, I'm just going to give you the most basic version of it. The mu receptor is the most well-known receptor, the one that we talk about most often. Most opioids bind to the mu receptor, and this is really responsible for the analgesia that we're seeking, as well as the most serious side effect, the respiratory depression, both mediated by activation of the mu opioid receptor. Pruritus, which is itching, and constipation, these also both happen at the mu receptor. The other receptors, the kappa and the delta and the sigma, seem to have other various functions. Analgesia does seem to occur at the kappa receptor as well. And some effects like nausea and vomiting, it's not exactly clear which receptor or receptors mediate that effect. When you bind an agonist to the mu or to any opioid receptor, this inhibits the release of excitatory neurotransmitters. It inhibits the response to excitatory neurotransmitters, all of these being located in your nociceptive neurons, in your pain-transmitting neurons. So these are really drugs that work at all levels, from the brain all the way down to the actual pain neurons, and block flow of painful signals. Opioid medications can be given by just about any route of administration. We are most familiar with the IV route, which is the most rapid and complete, of course. These drugs can be given IM morphine and IM meperidine have been used for many decades. And at that point, absorption may be a little bit slower, as long as 20 to 60 minutes. Oral administration, generally about 15 to 30 minutes of absorption. Transmucosal absorption is available. Most commonly, fentanyl can be absorbed through mucous membranes like the mouth or the lining of the mouth, and this is absorbed quickly in about 10 minutes. And then transdermal absorption is available. There are fentanyl patches, which usually take about 14 to 24 hours to build up a level. Opioids can also be administered axially, which means in the epidural or the spinal space. These drugs then diffuse to the opioid receptors that are in the spinal cord, and this has a lot of advantages. When we use an opioid in the spinal cord, compared with, say, a local anesthetic, we don't get a sympathectomy, we don't get any motor blockade, we don't get loss of proprioception, we don't really get numbness, and these are all what we usually think of as negative side effects of local anesthetics in the neuraxial space. The opioids are especially good for specific visceral pain rather than somatic analgesia. So they're not as good for like a sharp cut to your leg or a broken bone, although they'll help, but they're very good for the pain associated with organs or your digestive tract or something like that. Morphine can be converted between IV and epidural and intrathecal dosing at a ratio of about 10 to 1. So 10 milligrams of IV morphine is equivalent to about a milligram of epidural morphine, which is equivalent to about 0.1 milligrams or 100 micrograms of intrathecal morphine. This conversion doesn't work as well with the very lipid-soluble drugs like fentanyl. because these drugs actually will leach out of the neuraxial space and into the systemic circulation. Just to go over the pharmacokinetics of opioids very briefly, most of these drugs have a distribution half-life of 5 to 20 minutes. They are able to cross the blood-brain barrier because they're non-ionized and they're relatively lipid-soluble. Some of these drugs have a first-pass uptake in the lungs, especially fentanyl, and certainly small doses are redistributed very quickly into the peripheral compartment. So we see a relatively quick onset of action and then a redistribution. The drugs are then biotransformed, primarily in the liver. Some of our opioids, like morphine and meperidine, have active metabolites, which means that after metabolism, the metabolite still has some sort of an effect, whether it's an analgesic effect or perhaps just a respiratory depression effect. Other drugs, the more synthetic drugs like fentanyl and its relatives, have inactive metabolites, so more of a clean drug, and this would be useful in patients with renal disease. Remifentanil actually has a unique biotransformation that we'll see later. It undergoes ester hydrolysis, sort of like succinylcholine, although it happens by plasma esterases, not pseudocholinesterase. And then pretty much all of these drugs, except for remifentanil, are then excreted in the urine. And once again, morphine, which is sort of lipid-soluble, is not very well secreted in the urine. But once it's been biotransformed to morphine 3-glucuronide or morphine 6-glucuronide, and the same with normeperidine, all of these drugs are easily cleared through the kidneys. Before we get into specific drugs, we should discuss opioid tolerance and dependence. I'm not going to get into the whole discussion of illicit opioid use in anesthesia providers, but we should be aware of what these drugs do to our patients, both in the acute setting and in the chronic setting. Patients can become tolerant to opioid drugs after just a couple weeks, usually 2 to 3 weeks. And remember, tolerance means that you don't get as much of an effect from the same dose of medication compared to what you used to get as an effect. So people become tolerant to analgesia, to the euphoria, to the sedation, to the respiratory depression, and we will see patients who take hundreds of milligrams of morphine on a daily basis without any compromise to their respiratory depression. But actually, the one thing that people often don't develop tolerance to is constipation, and this can be an ongoing problem for patients who take chronic opioids. Addiction is different than tolerance. Addiction is an actual physical or psychological dependence on a drug, and it usually takes about 3 weeks. It takes about 25 days to develop an addiction, although some studies have shown that a very early form of addiction can occur as early as 48 hours after the first administration. And different drugs have properties that can make them more or less likely to precipitate addiction. But addiction is any sort of physical or psychological dependence. So whether it's your feeling of tremulousness when you haven't had a drink because you drink every day, or whether it's just being anxious and not knowing what to do with your hands because you haven't had a cigarette, those are all forms of addiction. Addiction to opioids is real, and when people don't get their opioids, they can go into withdrawal. Now, we talked about benzodiazepine withdrawal and said that it was a life-threatening, potentially life-threatening syndrome. That is not the case with opioid withdrawal. This is not really a life-threatening situation, although it's very, very unpleasant, and unfortunately it lasts for up to 7 to 10 days. The common signs of opioid withdrawal are what they call the superflu. So patients get a runny nose and they're sneezing and yawning and tearing. They get cramps, they get nauseated and they vomit and they have diarrhea. They can have piloerection, which is goose flesh. That's where the term quitting cold turkey may come from. And they get very dilated pupils. This can start within about 2 to 3 days of having your last dose of opioid, and like I said, can last more than a week. Things you don't commonly see would be seizures or changes in mental status or hallucinations. Those are things you might see in opioid or alcohol, in benzodiazepine or alcohol withdrawal, but not typically in opioid withdrawal. It's for this reason, because of these terrible side effects, that it's so hard for people to quit opioids, and a lot of people will go on something like methadone just to have long-term maintenance of their opioid levels so they don't go into withdrawal. This is a good time for us to pause so you can take note of any questions you may have, and we can discuss them in class or sooner if you want to get in touch with me. Now we're going to move on to morphine. Morphine is a strong opioid agonist and really the template for all of the opioids that we're going to discuss today. Morphine acts at the mu opioid receptors, among others. Opioids like morphine can actually decrease your MAC to about 65% of normal because they interact with the volatile anesthetics that we administer. As an opioid, it crosses the blood-brain barrier relatively slowly. It takes about 5 minutes for onset of action after you give a dose of morphine IV. But the peak effect might not occur until somewhere between 10 and 40 minutes. So if you give a dose of morphine every 5 minutes, you may be administering the dose to a patient whose pain is uncontrolled, but by the time a few doses go in, stacked one after the other, the patient may actually develop respiratory depression. It is a protein-bound drug. It undergoes rapid redistribution, like all of our lipid-soluble drugs do, and its elimination half-life is about 2 to 3 hours. This value is age-dependent, so in neonates it can be more than twice this amount of time, and even in the elderly patients we do see a slower elimination half-time. The drug is metabolized in the liver under high hepatic extraction conditions, so if hepatic flow is decreased, this doesn't really affect elimination. As we discussed, there are active metabolites, the morphine 3 and morphine 6 glucuronate, and these are excreted in the urine. So we need to be careful in patients who have renal failure because those metabolites can still cause respiratory depression. They are active metabolites. Morphine is reversed by naloxone, which is also called Narcan, and we'll speak about that again very soon. The effects of morphine and the other opioids like it. First of all, sedation. So people do become sedated. They can have cognitive impairment. They have a feeling of euphoria. Some opioids more than others. In the brain, it decreases everything, your ICP and your blood flow and your metabolic rate, as long as normocarbia is maintained. Remember, if a patient starts to hypoventilate, which we're going to see next, and then their CO2 goes up, and so that will actually increase cerebral blood flow. So in a ventilated patient, morphine will decrease your cerebral blood flow, but in a spontaneously breathing patient, morphine could actually have the opposite effect. It causes pinpoint pupils, pupillary constriction, which is called miosis. The opposite of that, by the way, is mydriasis. And it causes the itching, the pruritus. Classically, people described patients becoming rigid from high doses of opioids. This isn't something we see a lot of today, but people can actually become so rigid that they get what's called a wooden chest and you can't bag mask ventilate them. And of course, the nausea and vomiting, probably due to your chemo trigger zone in your medulla, which is one of the vomiting centers in your brain. In the respiratory system, hypoventilation is what we see. So patients they ventilate less liters per minute, and as their CO2 builds up, they have a lowered hypercapnic drive. They're not as responsive to increasing levels of CO2. And this can happen really at any point during the administration of morphine. It doesn't have to happen right at the onset, but it can happen after several hours of morphine therapy. The classic picture of a patient who's had too much morphine is apnea but arousable. So the patient isn't breathing, but if you shake them or wake them up, they'll take a breath, and then they'll sort of fall back to sleep and breathe 3-4 times a minute, and slowly go back into apnea until you wake them up and remind them to breathe again. And this would continue as long as their CO2 hasn't climbed so much that they're actually narcotized from the CO2, at which point they really need manual ventilation. Morphine decreases the cough reflex, and a lot of strong cough medications contain morphine or codeine or some other opioid medication. In the GI system, constipation is the biggest problem. The motility of the entire GI system is slowed by morphine. We also see increased tone in the common bile duct and spasm of the biliary system. This is called the sphincter of Oddi, and so some patients who have gallbladder disease or are having gallbladder surgery you may want to reconsider whether you should give an opioid medication, as it could impair clearance through the biliary system. Similarly, in the genitourinary system, we see urinary retention. Morphine in particular causes histamine release, which can lead to hypotension. Now, some people have used this as a positive side effect, where they've tried to prevent a stress response by giving high doses of morphine, or preventing an inflammatory response when a patient is put onto cardiopulmonary bypass. And in the cardiovascular system, we see hypotension once you give higher doses of morphine. And this is probably more of an issue in patients who have a high sympathetic tone to begin with. So patients upset and they're in pain and they're hypertensive, those patients, you'll see the blood pressure drop a lot. But if you take a normal, healthy, calm patient who's not in pain and give them some morphine, you probably won't see their blood pressure drop quite as dramatically. And at higher doses, the opioids tend to cause bradycardia. There are other opioid agonists that work similarly to morphine. The one you probably see most often is hydromorphone, also known as Dilaudid. It's about the same efficacy as morphine. It's also a strong agonist, but it's more potent, which means you don't need as much. A rule of thumb is that 1 of hydromorphone is equal to about 10 of morphine. A more accurate rule is about 1.5 of hydromorphone equals about 10 of morphine. The drug has no active metabolites, which makes it a better choice for renal patients or patients who are going to get prolonged therapy with opioid. Again, the length of action is about 3 to 4 hours, and we usually dose it at about 2 to 8 mics per kilogram. So in a 100 kilogram person, that's a dose of about 0.2 to 0.8 milligrams. Or you can just give 0.2 to 0.4 IV every 5 to 10 minutes. Methadone is a different sort of opioid. It has a very long duration of action. It's often used in the treatment of opioid withdrawal because, as we said before, patients who may not even want to be getting high anymore but don't want to go through withdrawal can take methadone once a day, and it will maintain their opioid receptors such that they don't go into withdrawal. But because it's a long-acting drug without very many peaks and troughs, they don't really get much of a high. It's also used a lot in treatment of chronic pain. It's actually a mu receptor agonist, but also an NMDA antagonist. And those two together seem to have special properties for the treatment of chronic pain. Heroin, which we hear about as a street drug, is actually produced by acetylating morphine. It is still technically available for treatment of pain clinically in Great Britain, although it really isn't used practically anymore. Because of the high that it gives. It gives a very fast CNS onset, tremendous euphoria, not a lot of nausea, and it is, as we all know, a very serious drug of abuse primarily. We'll stop here with this file. Again, any questions, feel free to let me know, and we'll pick up with the next section of this lecture.